Pharyngolaryngectomy, with radical neck dissection, without reconstruction. With reconstruction, the physician removes the larynx and pharynx. First, a tracheostomy is performed. The physician approaches the pharynx and larynx through a horizontal neck incision. The epiglottis, false vocal cords, mucosal lining of the ventricles, part or all of the hyoid bone, pharynx, and superior part of the laryngeal cartilage are removed. Extensive dissection may include removal of the sternocleidomastoid muscle, the submandibular salivary gland, the internal jugular vein and the lymph nodes of the lateral neck, under the chin and mandible, and the supraclavicular nodes. When either excision is completed, the incision is sutured in layers. In 31395, reconstruction of the pharyngeal area can be achieved in a number of ways. One of the most common is the myocutaneous flap reconstruction using the pectoralis major muscle and its overlying skin. The flap is rotated and inserted through a previously created tunnel between the clavicle and overlying skin. The flap is sutured into place to reconstruct the pharynx. The incision is sutured in layers. Laryngotomy, thyrotomy, laryngofissure, with removal of tumor or laryngocele, chordectomy. The physician first performs a tracheostomy on the patient. Using a horizontal neck incision, the physician exposes the larynx and performs a thyrotomy and laryngofissure, opening the larynx at the midline of the thyroid cartilage. The laryngocele or tumor is isolated, dissected, and excised. A chordectomy, the excision of all or part of the vocal cord, may also be performed. The incision is repaired in sutured layers. Pharyngostomy, fistulization of pharynx, external for feeding. The physician creates an opening to the pharynx for long-term feeding. The physician makes a horizontal incision below the jawline to create a communication between the pharyngeal lumen and the exterior of the patient's neck. The incision is sutured to create an opening for placement of a feeding tube. Crycopharyngeal Myotomy. The physician incises the crycopharyngeal muscle, also known as the upper esophageal sphincter, UES. The physician makes a lateral neck incision to expose the UES, and a second lateral incision through the UES. The incision is repaired with sutured layers. Cilolithotomy is a surgical incision of a salivary gland for removal of a calculus. Cilolithotomy, submandibular, submaxillary, sublingual or parotid, uncomplicated, intraoral. Complicated, intraoral. The physician makes an incision in the submandibular, sublingual, or parotid ducts to remove a cilolith, a stone. An incision is made intraorally in the mucosa overlying the duct and tissue is dissected to reach the duct. The physician removes the stone in a simple cilolithotomy. In 42335, a large stone and portion of surrounding tissue must be removed. The incision is usually not closed. Cilolithotomy, parotid, extraoral, or complicated intraoral. An incision is made extraorally in the skin overlying the gland and dissected to reach the stone or the intraoral mucosa overlying the duct is incised. Tissue is dissected to the gland. The physician removes the stone. The incision is closed with layered sutures.